Good morning and welcome back to another episode of House Calls, Real Docs, Real Talk. I'm your host, Sonia Azad. For those of you who follow along with us every Monday, you know that we took a little break from our programming because the American Heart Association Scientific Sessions was in full swing and we wanted to encourage all of you to attend. This year, Scientific Sessions was held entirely virtual for the very first time. It was a huge undertaking, as you can imagine, for the organization, but also an enormous success. Going 100% virtual was groundbreaking on its own, but just like every year at Sessions, it was filled with a lot of announcements and presentations on new studies and findings that will have enormous impact worldwide. So on today's show, we're going to examine some of the highlights of Scientific Sessions 2020 for you. And as always, your involvement is the key to our show. So before we go any further, stop, hit that share button or start a watch party. Let your friends and family know that you're watching and let's get them involved as well. Also, we hope you'll answer our viewer questions as we go along. To respond, all you need to do is text AHA Live to 22333. We don't need your name or any information. This is just a fun and easy way to answer. And if you don't want to text in, you can also just drop your answer in the comments section. All right. If everyone's ready, let's get started. With me this morning is Dr. Donald Lloyd-Jones, who is the chair of the Department of Preventive Medicine, Eileen M. Full Professor of Preventive Medicine, Cardiology, and Pediatrics at Northwestern Medicine. Good morning to you.
Thank you so much, Sonia. It's great to be with you.
Yeah, great to see you. I understand it's pretty cold in Chicago, so thank you for being indoors and taking the time. So before we start, let's start with our first viewer response question. So we want to dive right in. We want to know if those of you in our audience today attended Scientific Sessions, and let us know why or why not. So we do want to take it a step further. So you can also comment in the comments section. If you did attend, what did you think? If you didn't, why did you not attend? And while you answer that, we want to take a moment to mention that even though Scientific Sessions is over, everyone can still register to access all of the amazing content on demand through January 4th, 2021. So, for instance, if the dates didn't work for your schedule or if you were worried you wouldn't be able to attend enough of the conference to make it all worth the cost, all of that doesn't matter. It's all there for you to access whenever you want now through January 4th. And Doc, you had a pretty instrumental role in this whole thing, I understand.
Yeah, thanks, Sonia. I had the real honor this year of being the chair of AHA's Committee on Scientific Sessions Programming. So got to oversee the group that actually designed all of the content and picked some of the virtual platforms on which it was delivered. So it was a very exciting time. Lots of work went into this, but it was great to see it produced so well.
Yeah, and how did it go being all virtual?
You know, I think there's real value to this kind of format. I find myself still going back and catching things that I didn't have time to see at the time. I can be a little bit more selective in what I'm viewing and very targeted. So I think this kind of format is here to stay because it really does help us impart the science in ways that people can interact with it much more clearly.
Yeah, well, we're finding new ways to use technology, and it looks like a lot of you did as well. 43% of those of you attending and watching right now say that you did attend Scientific Sessions. So that's great. And for those of you who didn't but still would like to, hey, remember, till January 4th, you've got the opportunity to. All right, thank you guys for weighing in, and let's move on and get started with Health in the Headlines. All right, so here's how this works. Every week we select one current headline that ties back to the topic at hand, and then we ask our expert to respond. So this week's entry comes to us from, where else? Scientific Sessions 2020. So here's a headline. COVID-19 patients of all ages with obesity face higher risk of complications and death. So Dr. Lloyd-Jones, can you elaborate a little bit on what this study found and what our audience should know? I think that this is something that we've been talking about in the Western world, as we certainly saw COVID-19 sweeping across to the U.S., and we thought, oh gosh, this is going to be a big deal. And now we have the science, the evidence to back it.
Yeah, well, of course, it is a big deal. And this particular study, I'm really proud to say, was actually funded by the American Heart Association. Very early when the pandemic hit the US, the AHA pivoted, created this massive registry for hospitals to upload data on patients who are hospitalized with COVID-19. And we're already seeing important results out of that platform. So what this particular study highlighted was that we know that age certainly is a risk factor. We know that hypertension, existing cardiovascular disease, diabetes, all of these are risk factors for heart disease, but they're also risk factors for more severe COVID-19 infection and death from COVID-19. What this particular study highlighted, I think, was something that's also important to note. Obesity was strongly associated with complications and with death from COVID-19 as well. Complications means needing to go to the ICU, needing to have a breathing tube put in and being on a ventilator. And there was a dose response. So the heavier the patient was, the higher the risk that those complications might occur. And importantly, although we saw, of course, that age signal there, that older people seem to be more at risk, the thing that puts younger people at risk was obesity. And so I think this is a very important thing for people to pay attention to. If you are overweight or obese, make sure that you're focusing on your fitness, your health, your lung health, and making sure that if you do get COVID-19, you don't have these severe complications.
Was it just because of the respiratory issues or the cardiovascular issues, or was there more at play?
Yeah, that's a great question. I think there is a little bit more at play. Certainly, respiratory issues are a feature of people who are heavier. Their lung function isn't quite as good. But obesity itself tends to set up a chronic hyperinflammatory state. Our body's immune system is responding to a lot more things when people are overweight and obese, and that seems to be a way that the virus can actually amplify those inflammatory responses and increase the damage in the body.
Okay. Well, we're going to talk a lot more about this. Let's get into our main segment with live viewer questions. We call this You Ask, We Answer. And a reminder here, you can submit your questions as we're talking into that comment section or submit them to heart.org/housecalls. Now look, y'all know this, we get a lot of questions every week, so we pulled out some questions that were related to some of the late-breaking topics and findings covered at scientific sessions. Our first question comes to us from Tricia in Indiana, who asks, I've been hearing a lot about heart failure lately. What is heart failure, and are there new treatments for it? Dr. Lloyd-Jones, can you answer this for us?
And heart failure is not a heart attack. Heart failure is when there are problems with the heart muscle itself that might be due to a heart attack, but it could be due to a lot of other things also. So heart failure is a combination of symptoms, usually shortness of breath, often edema or swelling of the legs and extremities because of fluid retention. And the reasons why heart failure happens kind of fall into two buckets. One, if the muscle has been damaged so the pump is failing, or two, if the muscle pumping function is okay, but it can't relax, so it can't handle the volume needed to move the blood around the body. So a short definition of heart failure is just when the heart doesn't provide the blood output, essentially, that's needed for the body's basic mechanisms. So what's going on lately? Well, there are some new treatments for it. In the last couple of years, we've seen a whole new class of treatments emerge beyond just treating the fluid problem. These new class of medications, originally designed for diabetes, called SGLT2 inhibitors, actually do a really good job at treating heart failure as well. So we now have 4 different classes of medications that work synergistically together to treat heart failure. And at the most recent meetings, we now saw 2 newer ones, one that improves pumping function in people who have problems with the pumping function, and an old-fashioned one. Turns out that people who are iron deficient and have heart failure benefit from having that iron repleted. Now, it has to be done in a special way. You can't just take over-the-counter supplements. But this, I think, was both of these findings were very important steps forward in our ability to treat patients with heart failure.
Okay, we have our next question from April in Shreveport, who asks, I know that atrial fibrillation can put you at risk for stroke. How do I know if I have atrial fibrillation?
Right. Well, savvy consumer. So atrial fibrillation is an abnormal rhythm of the upper chambers of the heart where they don't contract normally. In that setting, blood clots can form inside that chamber break off and travel to other parts of the body, most commonly to the brain. And when a blood clot lodges in the brain, that's what causes a stroke. So a lot of people now are asking, how do I know if I have atrial fibrillation? Because it turns out many patients who have it don't have any symptoms from it. They can't tell when they're in atrial fibrillation and when they're not. So as you can imagine, there's been a lot of excitement and a lot of studies presented at sessions this year using newer technologies to try to screen for atrial fibrillation. In one, looking at patients after cardiac surgery, they found a lot more atrial fibrillation than we thought was going on after hospital discharge. And in other ones, people are using these things, these wearable technologies, to try to diagnose atrial fibrillation more reliably. And it turns out some of these consumer devices are getting pretty good at detecting it. They also have a false positive rate, though, meaning they overcall the diagnosis of atrial fibrillation. So it is important to get with your doctor and understand, what's reliable information and what's not.
I know. I've jumped on the bandwagon myself and monitor my heart rate and respiratory rate all day, every day. Okay, so let's get to our next question from Monica in Phoenix. This is a great question. She wants to know, why do women have different types of heart attacks than men?
Really important question. And I guess I would kind of tackle this from a couple different angles. First is, women's symptoms on average tend to be a little different than men's. We know for men, the classic sort of center of the chest, elephant sitting on your chest. In women, it can be more subtle, a little bit of shortness of breath, fatigue, perhaps more involvement in the arms or in the jaw. So it is important to again, pay attention to these symptoms. If you're just not sure, get yourself checked out. But there are other features too. Women seem to form plaques in their arteries a little bit differently than men do, which makes them a little harder to detect sometimes. And unfortunately, as a profession, we've not done a great job at treating women as aggressively as men when they're having a heart attack. And so in general, their outcomes tend to be a little bit worse as well.
Okay, our next one is a pretty specific question, but something a lot of us here may not know the answer to. So let's hear what it is. Kenneth in Portland is asking, I've heard about something called a polypill recently. Now, I don't even know if I said that right, Doc, so you can set me straight, but what is this for?
Yeah, polypill. So this is a concept that's been around for almost 20 years now. And it's particularly thought of as a way we might treat large populations more effectively to prevent specifically heart disease. So we know that, sometimes when we want to prevent things, we need to think about the cholesterol, we need to think about the blood pressure, maybe aspirin, other things. So patients who are generally healthy might not want to take a whole lot of pills, or it might be costly for them to take a whole lot of pills. So this polypill concept tries to think about, can we combine multiple medications that would be beneficial in prevention into one pill? So it's one pill, but it's got different components. And so in the most recent sessions, we had a large study report. This is the first large international trial to determine whether using this polypill strategy could actually reduce heart attack and stroke events. And it did. So I think you're going to hear a lot more about polypills. They're not currently available in the United States, but the polypill that was tested in that trial specifically included 4 different classes of medications: a beta blocker, a thiazide diuretic, an ACE inhibitor, and a statin. Now, I'm sure many of your viewers will be familiar with some of those classes, but a beta blocker, which regulates the heart rate, lowers the blood pressure a little bit; thiazide diuretic, very effective blood pressure lowering medication; ACE inhibitor, very effective blood pressure lowering medication that also protects the heart and kidney; and then the statin medication, specifically targeting that bad cholesterol. And when they combined those with a low dose aspirin, they found a 31% relative reduction in the incidence of heart attacks and strokes. So a real reduction in heart attack and stroke events. The question I think for many of us was, well, does aspirin really belong in there? This study was done in middle-income countries, places like India. When we've studied aspirin recently in places like the United States, it doesn't seem to add as much benefit, or the trade-off is there because sometimes aspirin can cause bleeding. So much more to learn about polypills. There are no polypills available in the US, as I said, and I think this study will actually push people to think about whether FDA should be approving one.
Yeah, I'm eager to see. Thank you for first of all teaching me something new today, and I'm eager to see where this goes in this country. Fascinating discussion, but let's press pause and we're going to ask another poll question. We'd like to hear from our viewers. So those of you at home or wherever you're watching from, grab your phone and get ready to text in your answer. As a reminder, all you need to do is text AHA Live to 22333 to answer. Now, if you already registered, you don't need to do it again. And if you're joining from your phone and it's easier, you can just drop your answer into the comments section. So with this question, we're sort of trying to better understand our viewers and your engagement with the American Heart Association. I know I'm eager to see the responses to this. So are you or have you been a professional member with the American Heart Association? That's the big question. I will say I'm sure we have a lot of people who are members, and certainly some of you where it's not applicable, so we completely understand. But while you all submit your answers, I want to show you a quick video that our very own guest recently participated in.
Why join as a professional partner of the American Heart Association? Because as a professional member, you're a part of something big. Through the American Heart Association, you can have an outsized impact on public health and patient care as you join forces with the nation's leading researchers, clinicians, scientists, and healthcare professionals. And that's on top of the many other benefits of membership, including career-enhancing collaboration and mentoring. Take it from this professional partner, my friend and colleague, Dr. Mercedes Carnathan.
I've been pleased to be a professional partner of the American Heart Association for the length of my career. Throughout the process, it's been instrumental in me making contacts that have expanded my science and that have provided me with leadership opportunities both within the American Heart Association and without. I enjoy the access to American Heart Association journals that help keep me on top of the science and also inform the directions that I take with my research, which has been generously funded by the American Heart Association. So overall, I've been extremely pleased with my partnership with the American Heart Association and can't say enough about what it has offered me as an opportunity to advocate for the prevention of cardiovascular diseases and stroke.
And Dr. Lloyd-Jones, would you like to say anything about professional partnership before we move on?
Well, thanks. Yes, HA is a remarkable organization. Not only is it a professional organization for clinicians, meaning physicians, nurses, other healthcare professionals, but it's also a very powerful public health organization. And I think it needs all of our support, particularly in times like these, to make sure that AHA and its amazing brand is advocating for things that really promote the public's health. Cardiovascular health is so central to that, but I think by being a member and engaging, you can advance the science, you can advance the research, you can advocate more strongly for the things that are going to make us all more healthy. So I couldn't be more pleased to be a member partner of AHA, and I hope all of you will consider joining as well.
Yeah, I hope so too. We were at about almost 60-40. The numbers are shifting a little bit, but those of you who say no, but I would like to be, hopefully by this time next week when we meet again, you will be. So something to put on your to-do list this week. All right, let's get back to the topic at hand and address a few more viewer questions. Here is one from Vernon in Wichita, Kansas. He asks, should I take fish oil to improve my health, to protect against heart attack or stroke? Now, this is interesting because it's something that I was doing until earlier this year when I learned a little bit more with new research. So I'm curious to see what you'll say.
Yeah, there's lots to unpack here. What a wonderful question. So I'm going to take it a little bit into parts. So I'd say the first thing is that we have zero evidence that over-the-counter fish oil supplements improve any form of your health. And part of the reason for that is the stuff that's over the counter is actually quite low dose. And part of it is that it's really not the right formulations or targeted to the right people. The best way to get fish oil, if you are healthy and part of the general population, is to eat fish. And the reasons for that are that you're still getting the benefits of the fish oil in the fish. And when you eat fish, you're not eating something else. Last thing I'll say about the diet and fish is important to eat the fish baked or broiled, much preferred over battered and deep fried, because then you're offsetting some of the benefits of eating fish. Now, as far as pharmaceutical fish oil, That's a much more complex story. So this is high dose refined fish oil that you can get with a prescription from your doctor. There's been a lot of debate in the medical community about what the benefits or harms of that might be. We now have multiple studies that have shown combinations of fish oil containing two things like DHA and EPA, two of the major components of fish oil, or omega-3 fatty acids, generally speaking, have not shown any significant benefit in reducing risks for heart attack, stroke, or other health outcomes. I'll say that again. Generally speaking, these combination fish oil pills, even at pharmaceutical doses, have not shown benefit. But one study using a very refined composition of what's called high-dose EPA or icosapent ethyl did show benefit, but we're still debating about how big that benefit was. So I think it's a conversation to have with your doctor. And importantly, you need to know that high-dose fish oil also increases the risk for atrial fibrillation that we were talking about earlier. So there are trade-offs, even if you think there's some benefit for you.
Now, I have to ask a follow-up. When you say eat fish, is that any particular kind of fish? Or I always hear salmon, but is that the best one? And then when you talk about where do you get your salmon, it's cold water is better or whatever. What do you suggest what would you say to patients?
Yeah, it's a great question. So in general, those fattier, oilier fish at the top of the food chain, what we're talking about here is salmon, mackerel, to a certain extent tuna, that eat a lot of smaller fish. They concentrate the fish oil, so those tend to be the better types of fish. And it is better if they are wild caught, because the farm-raised fish tend to be fed things like corn, which doesn't have a lot of fish oil in it, so they're not eating those smaller fish and concentrating the fish oil.
Okay, all right. Thank you for that. So Leslie from Plano, Texas, has our next question. She wants to know, what is the placebo effect and the nocebo effect? Dr. Lloyd-Jones.
Well, this one definitely clearly a savvy consumer coming right out of sessions. We had a lot of discussions about the placebo effect and the nocebo effect. I think people are pretty familiar with the placebo effect, meaning that, if we give you a sugar pill, if you're expecting to get benefit by being treated, in general, people feel better and they get more benefit than we would expect they should, because they're not getting an active treatment. The nocebo effect is the flip side of that. So the nocebo effect, when patients go in expecting a side effect or expecting an adverse outcome from taking a medicine, they are more likely to actually experience that side effect. So again, kind of two sides of the same coin. This came out most, I think, strikingly in sessions in one study that looked at how much of the side effects that had been attributed to statins were due to the fact of taking a pill, or how much were actually attributable to actually taking a statin medicine. So chemically, how much of those side effects were due to the statin and how much were just the brain playing a little bit of a trick on us to say, just by taking a pill, I may be getting more symptoms.
Okay, and this is almost a trick question, but I know you'll have an answer for us. Janice from Lincoln, Nebraska is asking, what is the best diet to follow? How do you answer this one?
Really important question. And, I think that it kind of depends on what your goals are, right? If your goals are general health, I think there's broad-based agreement on what we need to be doing. More fruits and vegetables, higher fiber, fewer simple starches and sugars, and protein's an important part of your diet, but it should be lean protein. Getting back to the fish we talked about, poultry, and avoiding the redder meats, which tend to have higher fat content. So, I think there's great agreement on that. The more you can fill your plate up with fruits and vegetables, the healthier you're likely to be. The less you eat packaged processed foods or foods that are prepared for you outside of your home, the healthier it's likely to be as well. So that's a general recommendation, I think, for people who are looking for an eating pattern that will help them reduce weight. The answer tends to be find what works for you. For some patients in my clinic, that means using some of these intermittent fasting protocols where they have 16 hours a day where they're eating nothing except water, and then they kind of focus their eating in the remaining 8 hours of the day, not overdoing it. For other patients, it's more about really increasing their physical activity and just limiting their calories a little bit. And for other types of patients, it may be more about, again, substitutions, finding those things in your eating pattern that are particularly high in calories or that particularly drive you to eat even more food, snack foods, high sugar foods, and making substitutions that are healthier. So I'd encourage you to talk with your doctor about what the best eating pattern might be for you, given your goals. But the good news is this is very doable. And if you're looking for weight loss, it doesn't matter how you do it. It matters that you do it. So find out what works for you.
I think that's great advice, and it is a little bit of trial and error, certainly. I find that intermittent fasting doesn't really work for me because I get what they call hangry after 16 hours. Okay, so hey, you guys, I see that there are tons of great questions coming in. That's all the time we have to get to questions live, but we're going to cover more of them in today's after show. So that's going to be available for you to watch later this week. Now, let's get to our latest segment called Triple Trivia. All right, Triple Trivia is sponsored by Crazy Cool Science, our new social media campaign that pumps up the fun in science. Science is everywhere, and Crazy Cool Science proves it. So we've got 3 trivia questions lined up to test your scientific knowledge. You can, again, drop your answer in the comments section or text in your answer, and we're going to find out who is really on their game today. All right, today's trivia covers a lot of different topics, just like our viewer questions, so we're going to dive right in. This first one is true or false. People can have a heart attack without any signs of a blocked artery. So take a couple of seconds here, think through this question. People can have a heart attack without any signs of a blocked artery. You can answer A for true, B for false. And when we did talk about heart failure. Should we go ahead and define, while people are going through this, a heart attack as well?
Is when usually a blood clot forms on top of a plaque in an artery that feeds the heart muscle. And if that blood clot is large enough to actually block the artery, it prohibits blood flow from getting to the downstream heart muscle. And within minutes, we can start to see heart cells die. And that is a heart attack. Now, there are other types of heart attacks where the plaque might be narrowing the artery just enough that if the heart increases its demand, increases in heart rate or blood pressure, there might be enough of a mismatch that the supply is outstripped by that demand, and that can cause heart muscle cells to start to die as well. So those are the kind of common mechanisms for a heart attack.
All right, and so right now a majority of our audience said A, true. Are they right?
They are right. You can certainly have a heart attack without having a significant amount of blockage in an artery, and this is often something we call MINOCA, or myocardial infarction, heart attack, with no obstructive coronary artery disease. It's particularly common in women and accounts for as much as 10 to 15% of all heart attacks. So really important data that came out of sessions this year on this, when they studied these women in detail who had this heart attack with no obstructions in their coronary arteries. If they looked very carefully, in about 20%, they could find another reason for having this heart attack, often some inflammation in the heart from a viral infection. But in about 80%, it was pretty clear it was good old-fashioned artery plaques that cause most heart attacks. So we need to not blow those women off, not say, yeah, no problem. We need to be treating them fairly aggressively to make sure that those plaques can't cause further heart attacks down the road.
Yeah, that's a big sort of area of discussion in the world of cardiologists, I understand. Not blowing those women off and listening to what they say. Okay, next question. Let's get to it. New research at Sessions this year looked at the main cause of side effects in people taking statins. So what did researchers find was the cause? So here are your options. A, the climate in which the patient lives. B, the actual action of taking any tablet. C, sitting down for too long after taking statins. Or D, the statin medication itself causing side effects. So you guys go ahead and take a little bit of time to answer. And I'm wondering, there are different classes of medications that we've been talking about. And when it comes to statins, I know that even, young children with something called hypercholesterol, familiar FHA, right?
Familial hypercholesterolemia.
Thank you so much. I thought I could say it.
It takes some practice.
So I know, young kids take statins these days. What is the latest research around that for those kids?
Yeah. Well, so familial hypercholesterolemia is a genetic disorder, a very specific genetic disorder, and those patients have extraordinarily high levels of their bad cholesterol because they don't make enough of the receptor that can clear it out of their blood. So it builds up in the bloodstream. And those are the patients who can have heart attacks from their high cholesterol levels in their teens and 20s, even if it's severe, but certainly by 30s and 40s, we see those patients. So they need to be identified. So screening is important, and then they need to be treated early. And statins are really the mainstay for reducing risk for heart attacks and strokes in patients with for any reason where we're trying to reduce their risk by lowering their cholesterol levels.
And usually the kids who are screened are like middle school athletes, or I always think of football players where they have screenings, let's say, before the season starts in high school to screen for any sort of problem, an enlarged heart muscle or anything like that. Is that sort of the only way to do these screenings?
Well, so actually, if we're looking specifically for cholesterol issues, if it's in the family, we recommend screening in very young children, 2-3 years old.
Oh.
For the general population, the general pediatric population, they should have a cholesterol test by the time they're 8 to 11 years old,
Wow.
just because this can crop up on its own. And so we need to find those people as early as possible.
Okay. All right. So we've got some votes in, and it looks like B or D is winning here. So when it comes to the new research that was looked at, the main cause of side effects in people taking statins, Doc, tell us the answer.
The correct answer here in this very interesting study was B. It was actually the act of taking any pill that drove most of the symptoms in these particular people. Now, let me explain that. So these were 60 patients who had abandoned taking statins because of severe side effects. So they had had a lot of muscle aches, or they had had fogginess, some of the things that people sometimes notice when they're taking medications. So they took these 60 patients, they gave them 12 pill bottles, 12 monthly pill bottles, and asked them to take them in random order. And they assigned the random order of those pill bottles. So the patients could open their pill bottle on day 1 of the month, and it might be empty. So they would take no pills that month. They could open a pill bottle, and it would contain a pill in it, but they didn't know that it was a placebo. Or they could open the pill bottle and find that for that month they were taking a pill, but they didn't know that it was actually a statin. And they were actually asked to chart their symptom score every single day for a year. So regardless of what they were taking, they charted their symptom score. What they found, fascinating, when patients were taking no pills, they had pretty low symptom scores on average. When they were taking the statins, remember these were patients who had had side effects already in statins, they had significantly higher symptom scores when they were taking the statins, although they didn't know they were taking a statin. And then finally, when they were taking the placebo, the symptom scores were just as high as when they were taking the statin. So fascinating, right? Let me just say, no question, there are patients who have real side effects to statins, no question at all. But I think there's another thing at play here. Our brain sometimes plays tricks on us and can magnify the symptoms that we do have and make them feel more severe because we don't really want to be taking a pill at all. So I think what this tells us as practitioners is we have to take side effects to medications very seriously. We need to understand whether patients have some of those symptoms before we start them on the pill. We need to document clearly what the symptoms are that the patient is feeling and have them maybe keep a diary. And we have to level set expectations when patients start a new pill, statin or any other kind of pill, to understand what the benefits are and what the potential for side effects are. In statin's case, those side effects are usually nuisance side effects, things that we can take care of if we either just adjust the dose or switch to a different statin within the same class.
Fascinating. Okay, let's take our last trivia question for the day. Researchers at the Cleveland Clinic shared a study at Sessions this year that investigated the post-hospitalization outcomes of heart failure patients who were provided a new health tool. So what were patients provided with? And here are your options. A is going to be a water bottle that has helpful tips for self-care written on the side. B, a large packet with information hidden on the 22nd page about how to improve health outcomes. C, an electronic card that engages patients with helpful information in an accessible way. Or D, it looks like a small house plant. All right. I'm really curious to see what folks say here. So Doc, what can you tell us about this new health tool?
Boy, I'd love to think it was the houseplant. That would be kind of cool and pretty easy, right? But in fact, it was this really nicely designed greeting card, just like you might get for your birthday, that had 4 different audio buttons in it, so that at discharge from the hospital, after a heart failure hospitalization, the patient could listen to these instructions rather than having to read the stacks of paper that we give them. And they could listen again and again after they took it home. And there were tips like lifestyle things that they need to follow, how to manage themselves, measure their weight every day, the importance of taking their medications, and when to call if they're having trouble. And those kind of 4 little audio reminders significantly improved people's likelihood of coming back to the emergency room with more heart failure, and improved patients kind of feeling empowered to care for their own heart failure. So a really nice demonstration of what we call implementation, making sure that patients are getting the therapies that we know that work well, by helping train them and helping them interface with that care much more effectively.
Yeah, I can imagine that's a lot easier for people. I'm just thinking of my own family where English was a second language. Is this offered yet in other languages like Spanish?
I believe they did have or are working on a Spanish translation, and I think having demonstrated this now, I think it's likely that they'll continue to do those translations for other languages as well.
Okay, yeah, I think that'd be really helpful. You guys did a great job on these trivia questions today. You're really top notch. This is a smart crowd. Okay, those were really interesting facts, and I imagine a lot of us, myself included, learned something new from that. So Dr. Lloyd Jones, thank you so much for your time today and for kind of taking us through all of these exciting discoveries. Do you have any final thoughts or parting words?
Well, I think Scientific Sessions was just so amazing this year. In a remarkable year, we were able, I think, to pull off a remarkable sessions. And if you haven't registered, please register. There's so much good science there and so many good sessions that teach you how to care for your patients if you're a doc. So I would just recommend, take advantage of the full time you have until January 4th to look at all the content that you can. And thanks to your viewers for really, really wonderful questions.
Well, we thank you again. Quite an interesting show today, as always. Let's round it out with a fun health hack. And this week, Health Hacks is brought to you by Stories of the Relentless. This is the American Heart Association's podcast, okay? You can go to heart.org, iTunes, Spotify, or Google Play to find a variety of amazing stories that you're going to want to share with your friends and family. All right, now for the health hack. This week's comes to us from Felicia. Now, I love this one because I do yoga and meditation teaching, but Felicia has been practicing mindfulness for a while now while she's been working from home. So she says, take the time to stretch, step outside, go to a different room, change your focus, just do some basic stretching. I love that, thank you for that. And use reoccurring sounds, maybe like church bells, to remind you to take a few deep breaths or repeat a positive affirmation. Felicia, you are on the right track here. We must all learn to step away from these screens throughout the day. It's so good for your mind and your body. Remember, we feature a new tip every week, so if you've got a great idea, you can send it to us at heart.org/housecalls. And hey, your idea might be here live on the show. That does it for us today. You can find any of our previous shows at heart.org/housecalls. And don't forget, since there are always more questions than we have time to get to, if we didn't get to yours today, you can check out the House Calls after show. So look for that on Thursday on the American Heart Association's YouTube channel. Thanks so much for tuning in with me this morning. I'm Sonia Azad. I'll see you right here next Monday.
Learn more about House Calls, Real Docs, Real Talk, and submit your questions at heart.org/housecalls.